All right, I think everybody is in from the waiting room. Welcome to, I guess this is the second talk on our virtual Fellows Trank Symposium. I'm DB Sanders, and Jim Schmiel and I are the co-chairs for this session. Thanks again for everybody who's joined and registered. Looks like we have over 40 participants so far. I have just a couple introduction slides or housekeeping slides, and then I'll hand it over to Chris Oermann for our talk today. Dr. Oermann is going to be speaking on congenital abnormalities of the lower airways and lungs. As a reminder, if you have questions, feel free to type them into the chat, and Dr. Schmiel and I will keep an eye on those and either stop Dr. Oermann to answer the questions, or we can discuss those at the end. If some of the questions may be more difficult, feel free to raise your hand and we can unmute you so you can ask your question. Please also give, excuse me, so the next talk will be next Wednesday at 4 o'clock Eastern. Dr. Catan will be speaking on respiratory disorders associated with immunodeficiency disorders. There's a QR code on your screen so you can register for that. Please register ahead of time for that. There's also a QR code to give feedback on today's webinar. These are really helpful to us, and we've definitely made changes based on feedback from attendees. So please, at the end of the session, go ahead and provide feedback. There will also be a SurveyMonkey link in the chat before the end of the talk that you can link on. And then the last slide I have before we start our talk is just an FYI for anybody who's interested in critical care training from ETS for COVID-19. And this is really designed for non-critical care physicians to learn something about treatment of COVID-19 and the ARDS, either for their understanding or just in case that may be part of your job description. So let me switch over to Dr. Oermann's talk, which I don't see. Try this again. All right, this is what I have to do. There it is. Okay, got it. Okay. So Dr. Oermann, as I mentioned, we're talking about congenital abnormalities of the lower airway and lungs. It's coming to us from Children's Mercy, Kansas City. Thank you again for giving us this talk today. Just let me know when you want me to advance the slides.
Go ahead, DB. Thank you for the introduction. So a couple of things we want to try and do in the next 45 minutes or so. I'm going to review the 5 stages of fetal lung development. And it's really important to understand what goes on during each of these stages so that you can truly understand how these congenital abnormalities develop and how they are manifested clinically based on developmental stages of the lung. We're also going to talk just a little bit about how these congenital abnormalities are identified and managed prenatally. We'll talk a little bit about the current classification scheme that we use for congenital abnormalities. And then we'll get into the meat of the talk, which is really a comparison of the clinical characteristics, pathology, and management of the more common congenital abnormalities that we see. And then we'll have a really brief talk about long-term prognosis. Next slide. So everything really starts with embryology. And as I said, you really have to have a good understanding of the embryology of these abnormalities to understand how they present clinically, as well as to pass your board. So this is really fundamental information for a pediatric pulmonologist and to know how to move forward in your careers. Next slide. So the embryogenesis of the lungs is incredibly complicated, and it requires very, very precise interactions, both temporally in terms of when specific cell lines emerge, as well as spatially, so that if you have some sort of anatomic abnormality that develops early in embryogenesis, that's going to have trickle-down effects and result in abnormalities in downstream tissues and development. So these master control genes code for a huge variety of different transcription factors, growth factors, cell adhesion factors, and a lot of other chemical signals that we don't fully understand. But again, these things have to interact very precisely, temporally, and spatially to have normal lung development. So what you need to remember from this slide is that the lungs develop from this outpouching on the ventral surface of the foregut during the 4th week of gestation, or by the 4th week of gestation. So you start off with a combined respiratory and GI tract, and this outpouching then gets pinched off to form separate trachea and esophagus later in gestation. It's also important to remember that the respiratory epithelium develops from endoderm, whereas all the support structures, the pleural vasculature, airway support, nervous tissue, etc., develop from mesoderm. So next slide. So the first stage of development is called the embryonic period, and it stretches from the 4th to the 6th week of development. And during this period, we see this foregut endoderm forming tubules off the ventral surface of the embryo, and these tubules then invade the splanchnic mesoderm, which is where all those support structures come from. So by the end of week 6 of gestation, we see the formation of the mainstem, lobar, and segmental bronchi. These very, very rudimentary airways are lined with pretty bland columnar epithelium, not the complex respiratory epithelium that we see in fully developed lungs. During this time, there are some very, very rudimentary blood vessels that start to form, although we don't see any cartilage, smooth muscle nerves, or any other respiratory tissues. Next. So the pseudoglandular period is the next stage of development. It occurs weeks 7 through 16 of gestation, and there is very rapid continued development of the airways at this time, and we see development down to the level of the terminal bronchioles, as well as some very primitive acini start to form towards the end of that 16th week. So there's a lot of epithelial differentiation with the emergence of multiple cell types that occur during this period, and we see a little more typical respiratory epithelium with mucus and other types of cells, as well as, most importantly, we start to see the cells that will eventually produce surfactant proteins A, B, and C, as well as neuroepithelial cells. We see a lot of development of vascular structures as well, and we're starting to see some early cartilage and smooth muscle development. Next. Canalicular period is week 16 through 26 of gestation. And again, there's a lot of rapid development that goes on during this 10-week period. We see development of the respiratory bronchioles, so smaller airways that have alveoli attached and are capable of gas exchange. We see a little bit of maturation of the acini, as well as the formation of some primitive alveoli, so that by 26 weeks of gestation, the lungs are capable of some degree of gas exchange. There's ongoing epithelial differentiation, and what we see is a transition distally in the airways from typical respiratory epithelium to more cuboidal cells that line the distal airways and are very metabolically active, producing a lot of the substance that mature lungs will eventually produce. And there's ongoing vascularization, and we start to see very early capillary networks that really form a mesh around the primitive acini and alveoli. Next. So during the saccular period, we mostly see maturation of existing structures. The acini are very well developed by this point. The primitive alveoli are starting to show significant maturation, particularly by the end of that 36th week. And we see conversion of these cuboidal cells to squamous type 1 pneumocytes in the alveoli, where we're really capable of fully functional gas exchange by that 36th week. We also see a very robust, well differentiated capillary network, as well as support structures throughout the rest of the lung parenchyma. Next. The alveolar period is really a period of maturation of existing structures where we see increasing size as well as number of alveoli through delivery and then complete maturation of all the other lung tissues. It's important to remember that even beyond these 5 stages of embryonic development, the lungs do continue to grow and develop postpartum. And we see ongoing alveolar development at least until the age of 5 or 6, probably until 10 years of age. And there's some recent information that says it may continue through the end of puberty. So we see increasing numbers of alveoli as well as increasing size of alveoli into adulthood. Next. So this is a nice figure that really summarizes all of that information. It goes through the 5 different stages, notable events being the development of the main stem, lobar, and segmental airways early in development in the embryonic period, more airway development through the pseudoglandular period, emergence of some early gas exchange at the end of the canalicular period, and then development through the saccular and alveolar periods. Next. So if you understand those 5 stages of development, it helps us to understand where these different congenital abnormalities probably occur. Again, during the embryonic stage, we tend to see tissue that is most compatible with that seen in Stocker type 0 CPAMs. Also, bronchogenic cysts very clearly develop during this pinching off of the trachea and the esophagus from the common tube, and abnormalities there will lead to bronchogenic cyst development. Extralobar sequestration probably occurs very early, where you have accessory lobes develop, and then tracheoesophageal fistulas also are probably occurring during that very early embryonic period where you have separation of the trachea and the esophagus. Stocker type 1 CPAMs are fairly primitive early developmental cells. And CDH, congenital diaphragmatic hernia, is not really a congenital abnormality, but the presence of loops of bowel or GI abdominal contents in the thorax markedly impacts the branching that goes on during the pseudoglandular stage. So you see simplification of the tracheobronchial tree. Other abnormalities, as we see, occur later and later in gestation, and sort of terminated in that alveolar period with Stocker type 4 CPAMs, as well as congenital lobar emphysema or overinflation. Next slide. So talking a little bit about prenatal identification and management of these lesions is what we'll do for the next couple minutes. Next. We have a question, and I'm not sure, we're supposed to be able to poll you guys, and we'll see if that works or not. So far, so good. And DB or Liz, how do they actually respond to this?
That's a good question.
It looks like something pops up for us where we can just answer.
Oh, good. Looks like 4 people have voted so far. All right, so it looks like the majority of people, 15 or 52%, chose the correct answer, which is D, that growth of these congenital abnormalities is extremely variable and unpredictable. So I think we can stop sharing the results. And go ahead and click to the next slide. All right. Can we move the poll?
I just closed it on mine.
I'm still seeing it.
Hit the X, you can close it.
Does DB need to do that?
I think everybody has to do it on their own terminals.
Okay. Thank you, Jim. All right, so prenatal diagnosis and management. Prenatal ultrasound has become almost universal in the developed world, and the technology is really, really impressive, and it's advanced a lot in recent decades. So it's really become possible to identify most of these cystic and solid lesions that we see early in gestation. Prenatal ultrasound also allows us to identify any associated congenital abnormalities of other organ systems, because some of these congenital lung abnormalities are also associated with abnormalities of other systems. The exception to that is that congenital lobar emphysema, or CLE, is not easily diagnosed by ultrasound because the lungs are uniformly filled with amniotic fluid, and there's nothing to differentiate the abnormal tissue from the normal tissue at that point in time. MRI is sometimes helpful in differentiating some types of lesions and is often used in fetal medicine centers around the country to try and delineate what some of these abnormalities are. But it's important to remember that definitive diagnosis really isn't possible prenatally, and it's best not to speculate when counseling prospective parents about what these lesions might be. And it's always a good idea to prepare for the worst case scenario of delivery, because some of these babies are really, really sick when they're born. Next. So as per the question, these congenital abnormalities demonstrate a lot of different behaviors in utero. Some of them remain relatively static, others get bigger. A lot of them seem to become smaller in size during gestation, and some actually appear to vanish completely, but that would be extremely uncommon. And again, one of the most important things you need to remember from this talk is that if an abnormality is identified, a cystic lung abnormality on prenatal ultrasound, those babies absolutely positively have to have postnatal imaging, even if the lesions seem to resolve completely based on prenatal ultrasound. The other thing to remember is that mass effect is really what causes problems here. And if you have large lesions that obstruct different portions of the lung, you can develop significant pulmonary hypoplasia, esophageal obstruction, which causes polyhydramnios. And most concerningly, you can develop hydrops, which is an ominous problem prenatally. Next. So what do we do with these guys when we are part of maternal fetal medical programs? All of these things really require pretty comprehensive evaluation when they're identified. In addition to routine ultrasound, there need to be specific attention paid to the heart with prenatal echocardiograms. Again, MRI is really helpful in trying to get better definition of what some of these lesions look like. And a lot of times genetic testing or karyotyping is helpful to get a good idea of what may be going on with infants that have a constellation of abnormalities. And intervention, fetal intervention, is really only appropriate if all of the comprehensive testing suggests that long-term outcome is going to be good for the infants. So luckily, less than 10% of prenatally identified abnormalities actually require fetal intervention. And really, hydrops is the determining factor. So any infant that doesn't develop hydrops should undergo spontaneous delivery. Infants greater than 32 weeks that do develop hydrops should have elective delivery, usually by C-section, because the benefits or the risks of prenatal delivery after 32 weeks are less than that of ongoing worsening hydrops. And then infants less than 32 weeks that develop hydrops will probably require some type of fetal intervention. Next. So what are those fetal interventions? Again, I'm not a pediatric surgeon, and I don't do maternal-fetal medicine all the time, but the typical things would be what you expect. Simple thoracentesis can be done, which is most helpful if you have a single large or dominant cyst, although it's sometimes necessary for repeat procedures to be done. Thoracoamniotic shunts can be placed. Again, they're most useful for single or dominant cysts. Fetal surgery can be done for multicystic lesions, and then so-called exit procedure, ex utero intrapartum therapy, involves delivering the infant via C-section while doing some type of surgery with the placenta intact to provide gas exchange for the unborn infant. Next. So I want to talk a little bit about classification, and this is where things get both a little bit confusing and at times a little bit contentious. Next. So historically, we've talked about 4 different classes or types of cystic abnormalities. The first one is congenital pulmonary airway malformation, or CPAM. We used to refer to these as CCAMs, which was congenital cystic adenomatoid malformation. But what we've seen is that most of these lesions are not actually adenomatous. So we have renamed them to remove that misnomer from the classification. We also see congenital lobar emphysema, or overinflation, pulmonary sequestration, which can be intralobar or extralobar, and then bronchogenic cysts. Next. So the reason this is somewhat confusing and contentious is that our understanding of these congenital abnormalities has changed a lot in the last couple of decades. What's become apparent in looking at tissue after resection is that there's a huge amount of overlap between a number of these lesions, particularly CPAMs and sequestrations, where you can have specific lesions that have characteristics of both. The other thing is that some of these lesions, once they're completely resected, don't really fit neatly into any of these existing classifications. So again, where there's lack of consensus, you can certainly have some controversy about how to describe these things. An important finding is that with a lot of the literature that's come out, there seems to be a common finding of bronchial atresia, stenosis, obstruction of some sort. And that type of obstruction, if you think back when I said things need to be temporally and spatially perfect in order to get normal lung development, any type of anatomic abnormality that causes airway obstruction is going to distort that spatial relationship and result in congenital abnormalities. So the last couple of things that I wanted to talk about as part of this conversation, although they're not really congenital cystic malformations, are congenital diaphragmatic hernia, and then esophageal atresia and tracheoesophageal fistula. Next. All right, clinical stuff, the good part. Next slide. All right, let's do another poll and see how that goes. So you saw the description, and the question is, I guess should I read those, or you're probably better off reading them yourself? I'll let you read them and then answer the question. So you have an infant with a presumed Stocker type 2 abnormality identified, and which of the following about Stocker type 2 lesions is true? Associated anomalies are rare, males and females are equally affected, most CPAM are type 2, and then pleural pulmonary blastoma is frequently associated with the lesion. And you guys came up with most CPAM are of this type, and that's actually incorrect. DB, can you go ahead and click? So the reality is that males and females are equally affected, and we'll talk about why each of these answers is true or not true. Next slide. So CPAMs are one of the more common congenital abnormalities that we see. The incidence is about 1 in 10,000 live births, and they are in fact equally distributed between males and females. Again, the majority of these are identified on prenatal ultrasound these days. We're currently using the Stocker classification, which was originally types 1, 2, and 3, and then types 0 and 4 were added later. Stocker zeros are very unusual, which is good. They clearly occur very early in gestation and are comprised of really small, tiny cysts that consist of tracheal or bronchial tissue. And because there's no gas exchange potential for this tissue, it's incompatible with life. Stocker type 1s are the most common, not Stocker type 2. So Stocker type 1 is 60 to 70% of cases that we see. They occur later in gestation than type 0. There's usually a single large cyst or at least a few large dominant cysts, usually 2 to 10 centimeters in diameter. And these are composed of bronchiolar tissue. The rest of the lung parenchyma is normal, so gas exchange is possible, unlike these Stocker type 0s. Next slide. So Stocker type 2s are the next most common type of lesion that we see, 15 to 20% of cases. They occur, again, a little bit later in gestation than the Stocker type 1s. And it's important that 60% of these are associated with other abnormalities, which could include heart, GI, liver, kidney, those types of things. So prognosis and life expectancy are a lot of times limited by some of these other abnormalities that we see with Stocker type 2 lesions. Stocker type 3 lesions are not very common, but are usually not very well tolerated. They occur fairly early in gestation, and we tend to see with these massive microcystic, almost solid appearing lesions, and because they are so large and bulky, they can take up an entire hemithorax and actually cause compression of the contralateral lung. So you get very severe pulmonary hypoplasia in these types of lesions. Stocker type 4, again, one of the newer things that we've talked about, 10 to 15% of the cases that we see, these are thought to occur fairly late in gestation. And again, you have a single large cyst, but they consist of alveolar tissue rather than the bronchial tissue that we see with the Stocker type 1s. And there's a strong association with these Stocker 4 lesions and something called pleural pulmonoblastoma that we'll talk about in a second. Important to remember that CPAMs are always and by definition connected to the airways, and there's equal distribution in all of the 5 different lobes. Next. So we used to think that most of these were symptomatic at birth, but as ultrasound has gotten better and we've identified more and more lesions, and particularly smaller lesions, it's now become apparent that only about a quarter of infants with these CPAM are actually symptomatic in the newborn period. When they are, it's usually due to a very large lesion, and they're tachypnic, they have respiratory distress, cyanosis, and those types of problems. 3/4 of infants with these lesions actually become symptomatic later in life, and this can be due to recurrent infection because, again, the lesions are always in association with the airways, but you can also see pneumothorax, hemorrhage from recurrent infection, and these things do have a possibility of malignant degeneration and can be identified later in life due to primary pulmonary malignancies. So I'm going to tell you that all CPAMs need to be resected. That is not a universally accepted approach, and there are places where they will sometimes observe small and asymptomatic lesions. The problem is that most of these will eventually become symptomatic due to recurrent infection. And again, there really is the possibility of malignant degeneration with these. It's been well documented, and that's not something that you want to let happen. So most of the people that I know recommend resection of all CPAMs, although in some places they will observe them at least for a period of time. Long-term outcome, usually good for Stocker type 1s. They're resected. You have significant compensatory growth and development of the lungs, and kids do fine. It's a little more variable for the type 2s. Like I say, they're a lot of times associated with other abnormalities that impact long-term outcomes. And then type 3s can be fairly bad as well. Next slide. So this is an interesting example of a type 1 CPAM, and this is a child that came into the emergency department not because they had any respiratory symptoms, but because he had, I think, a nickel lodged in his esophagus. So you can see up at the thoracic inlet, that's not a thyroid shield, that's a nickel stuck in the kid's esophagus. What was seen incidentally with the x-ray was this large right upper lobe cyst that you can see on the CT scan slides, where you have a very large cyst, including most of that right hemithorax, and there's a complete absence of any lung markings whatsoever, meaning this is truly a cyst, not a CLE. Next slide. So this is what the histology of these looks like, and the upper left panel is looking down into the primary cyst. You see some secondary loculations down there, but you have a very large primary cyst. It's lined with typical respiratory epithelium, columnar ciliated epithelium, so it's tissue consistent with fairly high up in the tracheobronchial tree at the bronchiolar level. Some of the walls of the cyst look a little more pre-acinar, but not very well developed. And then you see some smooth muscle in the wall of the cyst, but no cartilage. Next slide. This is what a typical type 2 CPAM looks like. Again, you see a right upper lobe lesion, but instead of having one giant cyst, you see a little more bubbly appearance, particularly on the CT scan, where you see lots of smaller cysts instead of the single large dominant cyst. Next slide. And this is what they typically look like. Again, a little more spongy appearance on the gross specimen with some smaller cysts throughout. And then the micro, where you see just tons and tons of what looks like relatively normal small airway tissue lined with more cuboidal looking cells. Next slide. So just a brief word about pleuropulmonary blastoma. It is the most common primary lung malignancy that we see in kids. It typically goes through 3 pathologic stages. If they're caught early, they appear almost purely cystic. As they mature, you start to see a mixed cystic and solid appearance. And then once these lesions have been present for a long time, they develop a more solid appearance and are very malignant and invasive by that time. They're associated mutations in the DICER1 gene, and genetic testing is always indicated when there are concerns about a type 4 CPAM and where pleuroblastoma is a consideration. And as I said, it can be difficult to differentiate the type 1 and the type 4 because both of them have a single dominant or large cyst. But things that suggest pleuropulmonary blastoma are a family history of malignancies. If you see multifocal or bilateral cysts, it's a very concerning finding. One of my colleagues in the last 6 months, she saw an infant that had been diagnosed with a CLE in the newborn period, had it resected, had an appearance of a new cystic lesion on the contralateral side. And she asked if CLEs ever did that. I said, no, but pleuropulmonary blastoma does, and underwent resection, and it was pleuropulmonary blastoma in the new lesions, as well as looking back at the older tissue from the initial resection, there was pleuropulmonary blastoma present there as well. So anything bilateral, multifocal really needs to raise your level of concern for pleuropulmonary blastoma. Other things that are concerning is a postnatal diagnosis. So these are not typically identified on prenatal ultrasound. They come later. And then pneumothorax is often suggestive of pleuropulmonary blastoma as well. Next slide. Another question. This is a 2-year-old with recurrent respiratory tract infections, and you are suspicious about a congenital lobar emphysema. And the question is, what would make a presentation of a 2-year-old boy abnormal. Age at presentation, location, male sex, or normal prenatal ultrasound. So it looks like we have got a small majority for age at presentation, which is the preferred answer. Next slide, DB. So congenital lobar emphysema is not as commonly seen as CPEMs, 1 to 20 to 30,000 live births. For unknown reasons, there's a strong male predominance, so that's not unusual in our case. The majority of these are not identified on prenatal ultrasound. If you recall, when I was talking about prenatal ultrasound earlier, before delivery, the lungs are universally filled with amniotic fluid, which doesn't differentiate CLEs from normal lung tissue. And it's only after the infants start breathing air that we see progressive hyperinflation of the involved lobe or lung. So most prenatal ultrasounds are normal when CLEs are identified. Most are also isolated abnormalities seen with other types of problems. Histologically, these things show normal but enlarged airways and alveoli. And for that reason, the term emphysema is really not accurate, because emphysema implies actual tissue destruction and damage. So some people prefer to use the term congenital lobar overinflation instead of emphysema. These are, again, by definition, connected to the airways, although in a lot of cases you can find a stenotic or obstructed airway that causes sort of a ball valve effect, where you have progressive air trapping distal to the obstruction. There is a strong upper lobe predominance, again, for unclear reasons. Next slide. So many of these will become symptomatic shortly after birth as babies transition to breathing air. There's progressive air trapping, and depending on the size of the lesion, they can become very symptomatic shortly after birth, and that occurs in 1/4 to 1/3 of CLEs. About half are symptomatic by a month of age, and virtually all of these kids are symptomatic by 6 months of age. So what made the presentation of this kid unusual is that he remained relatively symptom-free until he was 2 years of age, although retrospectively there were probably some indicators that something was not quite right with this kiddo. Chest x-rays are usually normal at birth, or if anything can show some opacification of the involved lobe, because there's amniotic fluid retention, so they can actually look dense immediately after delivery. But again, progressive hyperinflation, very characteristic findings as the babies continue to breathe room air. Respiratory distress, certainly common in large lesions early on. Smaller lesions that are presenting later, instead of respiratory distress, the kids often have sort of focal monophonic wheezing due to airway obstruction. They definitely have decreased breath sounds or air movements over the affected lobes, and they can have asymmetric chest shape as well. So most of these will need to be resected, because most of them are symptomatic, again, by 6 months of age. If they are truly identified in an asymptomatic kid as an incidental finding, they can probably be observed. Next slide. So this is actually the child from the vignette. As you can see, the chest x-ray obtained in clinic shows massive hyperinflation of the left upper lobe with some herniation towards the midline, as well as some mediastinal shift. So this kid was taken to the OR by Daryl Cass, one of the pediatric surgeons that I worked with. And as he made the incision for the thoracotomy, that entire left upper lobe just basically erupted out of the thoracotomy incision like a balloon. So he didn't pull this lung tissue out. It just spontaneously erupted up out of the incision, and that's what it looked like. Next slide. So this is what the gross specimen looks like, and on the left part of the slide you can see normal lung tissue that's collapsed after being removed from the thorax. That emphysematous lobe didn't deflate and stayed very sponge-like in its texture because there was gas that was permanently trapped in the air spaces. And then histologically on the right, you see very, very dilated air spaces, airways, alveoli, that are structurally normal, just very large and much larger than they should be. So that's the hallmark of CLEs. Next slide. Another question. I'll go ahead and let you guys read that. So the question is basically what differentiates extralobar sequestration from intralobar sequestration. And you guys actually took the bait, which was systemic arterial blood supply, which is common to both lesions. So that's not the right answer because both ELS and ILS have systemic blood supply coming directly from the aorta. So what actually differentiates ELS and ILS is that male gender is much more predominant in true ELS than ILS. And we'll talk about some of those details on the next slide. So these are really very rare lesions. Intralobar sequestration, about 1 in 200,000 live births, versus ELS, which is 1 in 800,000. So really very uncommon lesions. Again, extralobar sequestration is much more common in males than females, whereas ILS is equally distributed among sexes. ELS tends to be diagnosed more frequently on prenatal ultrasound, whereas ILS is diagnosed most commonly postnatally. Important things to remember are that they're both comprised of these microcystic abnormal masses of lung tissue. They are not connected to the airways, but both lesions have a systemic arterial connection coming from the aorta. Next slide. There doesn't seem to be any laterality, right versus left for sequestrations, but they're much more common in the lower lobes than they are in the upper lobes. And the reasons for this are not entirely clear. Important thing to remember is that ELS does have a separate pleura, so it's truly an accessory lobe, whereas intralobar sequestrations are contained within the pleura of an otherwise normal lobe. Symptoms can develop anywhere from birth to adulthood, more common in infancy with extralobar sequestrations, more commonly in older childhood with intralobar sequestration. Symptoms of ELS, again, in the neonatal period is often respiratory distress, whereas recurrent pneumonia is most common in intralobar sequestration. The other interesting thing is that ELS is not infrequently associated with other congenital abnormalities. And this constellation of findings to some people suggests that extralobar sequestration is truly a congenital problem, whereas intralobar sequestration may actually be an acquired problem caused by airway obstruction and recurrent infection or inflammation. So it's an interesting theory that has not been proven, but it does make some sense based on the epidemiologic findings that we just talked about. Next slide. So typically speaking, small asymptomatic ELS may be observed. ILS virtually always require resection because they are associated with recurrent infection and problems secondary to that. So this is a really great image of a little person that had an extralobar sequestration. And as you can see with the CT scans, there is some initial abnormality in the posterior part of the right lower lobe. As we move to the next section, you start to see a little bit more cystic dominance, although there's some solid portions as well. In the lower left CT scan, you start to see a bright aortic vessel coming from the aorta. And then in the lower right panel of the CT, you see a really large vessel coming directly off the aorta below the diaphragm. And in this 3D reconstruction of the vasculature, you can see that the vessel feeding this sequestration is almost as large as the descending aorta. So this is certainly a situation where even if the lesion is not causing respiratory symptoms, this child was certainly at risk for high output failure secondary to recirculation through this sequestration. And then you can see just sort of a conglomeration of venous drainage where it all comes together and feeds into the right atrium. So it's an interesting case and really great imaging. Next slide. So it's typically histology. Again, diffuse microcystic lesions. There's always a systemic artery, which is shown by the red arrow in the image on the left. Clearly abnormal lung tissue. Then on the right, you see the microscopic tissue. Next slide. All right, we have another question. So you're evaluating a 2-year-old referred for recurrent cough and wheeze. She has fixed low-pitched monophonic wheeze. Initial chest x-rays lead to a chest CT. And if you click that DB, we can see that. And if you click again, we'll see what the options are. So bronchogenic cyst, congenital lobar emphysema, congenital pulmonary airway malformation, or extralobar sequestration. And it looks like we're going to get 100% response for bronchogenic cyst, which is, number one, the only thing we haven't talked about yet. And it's just a really beautiful classic image for a bronchogenic cyst. So we can probably skip the rest of the polling and go to the next slide, DB. All right, bronchogenic cysts are relatively common, 1 in 20,000 live births, equally distributed between males and females, and are generally identified on prenatal ultrasound, although not always. These are invariably fluid filled with a kind of a thick gelatinous type of fluid. They're lined by respiratory epithelium. They have cartilage plates typical of airways, and they will usually have some gastric mucosa scattered in areas around the respiratory epithelium that's in there. They're not typically connected to the airways. The majority of them are mediastinal, about 2/3, although 1/3 of them occur in other locations. In the parenchyma, they can also occur below the diaphragm very infrequently. Next slide. So again, symptoms can develop anywhere from birth to child or birth to adulthood, depending on the size of the lesion and how much compression of airways there is. So there can be significant compromise immediately after delivery with really large lesions, although a lot of these are not identified until later due to recurrent coughing, this fixed monophonic wheeze, recurrent infection, or hemoptysis from pulmonary hemorrhage. usually not associated with other abnormalities. And again, the imaging on these, just from a simple chest x-ray, is often so classic that you can make the diagnosis there, although most of the kids will eventually get a CT to just better define the anatomy prior to surgical intervention. And again, all of these really do need to come out. And next slide, DB. So this is an older child that came in, and if you look at the AP view of the chest, you can sort of in retrospect identify that there's some fullness on the right parahilar region and maybe some narrowing of the airway. It's a little more clear on the lateral view where you see a nice rounded shape right in the middle of the mediastinum. And then those are the CT images that I showed you with a question, and they're just very, very classic for a bronchogenic cyst. Next slide. All right, this is the histology of that particular lesion. And as you open up the cyst, there's this, again, gelatinous sort of fluid from mucus produced by the respiratory mucosa. You see very typical respiratory epithelium lining the surface of the histology specimen. And the light area in the middle is a cartilage plate, which is really required to diagnose a bronchogenic cyst. That's the hallmark of the histologic diagnosis. And then you see some smooth muscle towards the bottom of that histology specimen. Next slide. All right, another question about congenital diaphragmatic hernias. If we're short on time, we can skip questions. What do you guys think? We'll go for questions. All right. So the question is, which of the following is true about congenital diaphragmatic hernias? There's complete opacification of the involved side. Morgagni hernias are most common. Most CDHs are on the left, or there's a strong male predominance. And it looks like most of you are correct that most congenital diaphragmatic hernias occur on the left side. Next slide. So relatively common, which is unfortunate because a lot of these kids are really, really sick right after they're born. The incidence is 2,500 to 5,000 live births, equally distributed between males and females. And if you recall embryology, the diaphragm actually forms in a couple of different parts, and these eventually fuse to form the complete diaphragm. And abnormalities in this migration and fusion of the diaphragm is what leads to diaphragmatic hernia. The posterolateral or Bochdalek type is much, much more common than the anterior central Morgagni type. As you guys know, the vast majority are left-sided, although some do occur on the right, and you can actually have liver that herniates up into the right thorax. The big problem with congenital diaphragmatic hernia is that you develop severe pulmonary hypoplasia and secondary pulmonary arterial hypertension, depending on the size of the lesion. Next slide. So this is a fairly typical radiograph. You can very clearly see that there are big loops of bowel that fill the entire left hemithorax. So clearly there is not opacification. This was a very sick child immediately after delivery. What you can see is that the thorax is fairly distended, particularly on the left side. The abdomen looks fairly small and diminutive because, again, much of the abdominal contents are in the left chest. Again, you can diagnose this typically just with a chest x-ray because those distinctive loops of bowel are present. The right-sided hernias where you have some liver up there are a little less easy and straightforward to diagnose simply with a chest radiograph. A lot of these, 50% or more, are associated with other congenital abnormalities. Next slide. So management really depends on the severity of respiratory distress. Fetal interventions are sometimes necessary if you've clearly got a large lesion where much of the diaphragm is absent and significant percentage of the abdominal contents are in the thorax. And what's been done is that the fetal surgeons will basically staple the trachea. The lungs are net producers of fluid during gestation. So as the lungs produce fluid, that helps to distend the involved lung and in theory will push some of the abdominal contents back out of the thorax into the abdomen as gestation continues. So when these kids are born, it's all about management. Many will require intubation and ventilation. Some will require ECMO due to the severity of the lesion and the secondary pulmonary hypoplasia and pulmonary hypertension. They virtually all need surgery at some point in time. And the big things that are of concern is that the pulmonary hypoplasia takes years to really resolve, and that these kids can have pulmonary hypertension that lingers for some time. And of course, like we said, a lot of these are associated with other congenital abnormalities and that can cause long-term issues as well. Next slide. So a question about esophageal atresia and tracheoesophageal fistula, and the most common configuration for those. Looks like the majority have said esophageal atresia with distal tracheoesophageal fistula, which is the answer that we're looking for. Next slide. All right, so this is a quick summary of esophageal atresia, tracheoesophageal fistula. Again, it's a relatively common lesion, 1 in 3,500 live births, equally distributed between males and females. And, you know, going back to early embryology where we have that outpouching from the ventral surface of the embryo where you have a common trachea and esophagus, eventually they are pinched off and separated. And that's undoubtedly where these occur, where you have defective pinching of the two different tubes. So there are 4 types that are typically described. The most common is what's called type C here, which is proximal atresia with a distal fistula. The proximal fistula and distal atresia are unusual. Having 2 is also unusual. And then we always hunt for the dreaded H-type fistula, but they're relatively uncommon. Things to think about are that these are always associated with very significant esophageal dysmotility, and after repair there is a strong tendency to develop esophageal strictures and narrowing with recurrent aspiration as a result. Then the other universal problem with these is that tracheomalacia is there due to abnormal cartilage formation where the fistula is located. Next slide. So clinically, always associated, at least the proximal pouches are associated with dysphagia, choking, gagging, etc., chronic cough with some of the H-type fistulas, as well as recurrent pneumonia later in life. Diagnosis is usually in the newborn period when you can't pass a catheter through the nose into the stomach, and you will see x-rays of these catheters curled up in the proximal esophageal pouch. If it's in question, you can do contrast studies, and the typical study done for these H-type fistulas is what's called a prone retrograde Trendelenburg esophagram, which is a technique known to radiologists to sort of maximize the ability to identify these H-type fistulas, which are hard to identify even on endoscopy because they can be quite small, and there's actually better chance of identifying these fistula with a contrast esophagram than there is sometimes with bronchoscopy. And again, many of these are often associated with other abnormalities, either charge or bacterial association. Next slide. And management is, again, repair the esophagus either directly or with a staged procedure, depending on the size of the gap, ligate the fistula. Long-term prognosis varies. Again, esophageal dysmotility with recurrent aspiration is almost universal, as is tracheomalacia. And the CT image on the right is from a little girl who wandered into a clinic one day from somewhere out in the middle of Kansas, having fallen through the cracks and not been followed for a number of years. And as you can see, she developed very, very significant bronchiectasis of the bilateral lower lobes due to recurrent aspiration. The good news is after about 2 years, go ahead and next slide, DB. 2 years of aggressive airway clearance, things had really resolved for the most part. So even though things looked pretty grim to start with, this young lady is really doing well clinically. Next slide. So what do we do with these guys? Next slide. So again, most of these are identified on prenatal ultrasound, although most of them, 3/4, are asymptomatic at delivery. Those that are symptomatic at delivery are really easy. They need early advanced imaging, typically a CT scan, and early resection. Things get a little more complicated in asymptomatic infants. They all should have an X-ray immediately after delivery. If there are indicators suggesting a high risk for problems, meaning large lesions or some concern about pleuropulmonary blastoma, those infants should also have early imaging and early surgical resection. For those that are deemed low risk, meaning small lesions, no symptoms, we typically recommend doing advanced imaging, usually a CT scan, although sometimes MRI, at about 6 months of age. It's technically easier to do and you get better imaging. If that confirms low risk, there are those who would recommend serial imaging, although it's not clear at what frequency imaging is necessary. But for most of these lesions, most surgeons in the United States would recommend elective resection around a year of age. If with that CT at 6 months, there are high-risk characteristics, then again, surgical resection early would be recommended. Next slide. All right, so in summary, most of these are identified by prenatal ultrasound, but have an extremely variable natural history. Some appear to disappear, but really don't. And therefore, you have to have advanced imaging postnatally on all of these infants, typically around 6 months of age. Again, most of them will require resection, the possible exceptions to that being small extralobar sequestrations and truly asymptomatic congenital lobar emphysema. Next slide. Prognosis is really pretty good for most of these. Considerations are that those that are associated with other congenital abnormalities have a slightly worse prognosis that may be based on the severity of those abnormalities. CPAM, which is associated with pleuropulmonary blastoma, again has a more guarded prognosis based on the stage of the PPB when it's identified, with those solid lesions being fairly aggressive and having not a very good prognosis. The prognosis of CDH largely depends on the degree of pulmonary hypoplasia and secondary pulmonary hypertension. And then TEF is usually a pretty good prognosis, although dysphagia with recurrent aspiration and tracheomalacia tend to be long-term problems that are dealt with for a while. And I think that's the last slide. And yep. All right. So DB, Jim, anything from your end?
I thought that was great, Chris. Thanks so much. I always enjoy hearing you speak. So I don't know if I'm looking at the chat. I don't know if there's any questions there. But if people want to go ahead and ask a question, let us know and we'll open up your mic. Or you can type it in the
So, yeah, it looks like one question's come in. How frequently do you follow patients with CPAM in clinic prior to surgery, and do you continue to follow them after resection?
Hey, Melika, good to hear/see from you again. Hope everything's going well in Dallas. So there's not a lot of need to see these kids frequently. Usually once they're identified, it's a good idea to get them involved with both the surgery clinic and the pulmonary clinic. And as long as the initial x-ray looks good, plan on getting the CT in association with a clinic visit at about 6 months. And then future planning really kind of depends on what that imaging looks like. I think it is a great idea for us to stay in contact with these kids. Again, most of them have pretty good prognosis. And there's been mixed data about long-term lung function. Some of the papers say that it's normal, others say that there are clear abnormalities, at least for a period of time. So I think it's important to keep these kids in the system, and certainly when they're old enough to do some pulmonary function testing to really know what's going on.
Chris, maybe while we're waiting for some more questions, have you seen a late presentation of congenital diaphragmatic hernia, and are those kids at any other risk for pulmonary hypertension? I've seen a couple where we actually had normal x-rays in the NICU, and then a few months later had new development of CDH. Yeah,
we've seen some kids where they've done well initially, and then there will be serial x-rays for just sort of non-specific pulmonary symptoms, and eventually somebody kind of says, this is a consistent, sort of cystic lucency in, the left lower lobe. Maybe it needs to be looked at a little more closely. So we do see those kids from time to time where smaller lesions can present later in life. And the other thing is sometimes if you have a diaphragmatic eventration rather than a true hernia, it's always a question that comes up: is it a hernia? Is it an eventration? So CT or ultrasound is a lot of times helpful in differentiating those two later.
All right, thanks. Brooke Farquhar has a question. In your experience, which abnormality do you think gets missed the most?
I think probably bronchogenic cysts are generally diagnosed later than some of the other ones, because frequently they are small and they can sometimes not be really obvious on prenatal ultrasound, and they don't become symptomatic until later, where you have progressive airway obstruction and this sort of chronic fixed low-pitched wheeze. I don't know that that's missed. It's that they truly don't become symptomatic until later. I think sequestrations can also present later, particularly the intralobar variety. And I think small extralobar sequestrations can be truly missed on prenatal ultrasounds. So I answered the question with a very long, non-specific answer.
All right. Another question Manju Hurwitz asked, for the type 4 stalkers CPAM, what's the annual risk of developing the PPV if resection is not done?
Wow, I have no idea. I don't know that they're frequent enough or that anybody sees enough to really come up with some type of risk. I don't know, DB, do you have any thoughts?
Yeah, I mean, I don't think I know the numbers. I feel like the consequences of letting that go on too long is enough that it comes out.
Yeah.
All right. Well, thanks again for that talk. It was really great. I know Jim and I like to sign on just so we refresh ourselves. And so the next talk will be next week, next Wednesday, Dr. Catan on HIV and immune deficiencies. Thanks for everybody for joining today.
Guys,
Thanks,
thank you.
Thanks,
Wish
Chris.
you all the best in your careers.
All right, thanks.